Recently, the SBS decided to sponsor an audiovisual historical archive to feature outstanding leaders and contributors in vascular surgery. A committee chaired by Dr. James Yao was formed to undertake these interviews with the help to preserve the impact of our most famous and distinguished colleagues. My name is Mark Eskandari, and today I will be interviewing Dr. Richard Dean. Dr. Dean, thank you for coming for the interview today. To get started, you currently reside in North Carolina.
That's correct.
But I'd like to begin in the early years when you were growing up in Virginia. So you were born in 1942 in Radford, Virginia, is that correct?
Right.
And I noticed that you attended the Virginia Military Institute.
That's correct.
I'm from the Midwest. I don't know much about the Virginia Military Institute. Can you tell us a little bit about that experience?
Well, you would not have had any legitimacy during the Civil War, but anyway, VMI was started in 1837, and I was in the centennial class of the Battle of Newmarket, one of the battles of the Shenandoah Valley. And my senior year, I think we marched at a parade for every single cadet that stumped his toe on the way to the Battle of Newmarket or got a cold.
Oh my.
But it's a very, one of the comments about VMIs is that at the time it was 150 years of tradition unhampered by progress. But it's a very military, old core kind of school. The only place I ever applied to go, I'd always wanted to go there.
Was there anybody in your family that had attended that beforehand?
My older brother had, but he was 6 years ahead of me at VMI. But since I was about knee-high to a grasshopper, that's where I was going to go to college and was going to go to the Medical College of Virginia, so I applied to one college and one medical school.
Okay. Now I've heard from other colleagues that there was a period of time at VMI called the rat years.
The rat year. That's
Could you
your
tell me a little bit
year.
about the rat years?
Well, the rat line, which is what you were called rats, and that's because you weren't up on the evolutionary scale to humans at that point. You have to eat what's called square meals and sit on the edge of your chair and march in a very rigorously right-angled march everywhere you went outside your room, inside the barracks. And I was quite lucky because I played rat football and then wrestled after that. And for my whole rat year, while the rat line was going on, I got to skip all of the military duty afternoons because I was doing something in the athletic team. And so I missed a lot of the rigors of the rat line because I was eating at a training table for athletes, so you didn't have to strain during the meals and the like. But
So a clever way to get out of
clever way, yeah. BMI, I've thought back on it, was the greatest lesson for a surgeon because it, in life in many ways, really, because it had an expert method of being able to teach you risk-benefit ratios. And if you wanted to do something that was against the military rules of the place, you had to weigh very heavily the benefits of having done it versus the cost of having done it and the severity of the penalty that you would get. So it leaves an impact on everybody that has ever gone there.
Do you still have ties there?
Well, I do. Since I retired, I have created a scholarship for a cadet out of Virginia who's interested in biology or the health sciences. And so I go back on an annual visit at this point for a black tie dinner. That's about all.
And do you have ties with any of your previous classmates? Because it almost seems like this would be...
It's a very
like
close-knit, the school. When I was there, we would beat Virginia Tech in football, although they were something like 20 times larger school than VMI, which had 1,100 students at the time. We would beat them in football every Thanksgiving Day. That was the big rivalry in the old days, in the old corps. But because I went from there to medical school, then to residency in surgery and on, I actually effectively disappeared from the bowels of BMI at that point and moved on with other things in my life until I've come back around at the ends of my life to get back in touch with it.
Tell me a little bit about your parents and your family growing up in Virginia at that time.
Well, my mother, school teacher education, and parented very similar to that. My father was a general practitioner. I have a great-grandfather that was a physician, a great-uncle that was a physician. My father was a physician, my older brother was a physician, and I was a physician. So my whole life I had planned for myself without much input from anybody else. Was, as I said, go to VMI, then to go to Medical College Virginia and be a doctor. And the one thing I knew I was not going to be when I entered medical school was a surgeon. The surgeons were somebody my father would call to take care of something in one of his patients, and so I thought that they were somewhere further back on the evolutionary scales at the time.
Okay.
But I found out differently.
So it sounds like things were pretty well mapped out for you at a young age.
It was. The first decision I ever had to make was, now what do I do now that I have my MD degree? You know, you have to go to residency somewhere. So that was my first decision, was where am I going to go do my residency?
Okay. So you went to Medical College of Virginia and graduated in 1968, and then decided to do your residency in surgery at Vanderbilt University. So as you say, when you first started, the whole idea of being a surgeon really was not a fact. It wasn't something you were considering. What led you to pursue a surgical career at that point?
Well, at the time, Medical College of Virginia had a program called a surgical externship, where a selected student from each class, select one, and you could, after your sophomore year, for the summer, for the next 2 summers, you could, and then so you worked every day and every other night, and then throughout the year, every 4th night, effectively as a acting intern, I had my own floor of MCV Hospital that I was the junior person on, and that turned me on to surgery. I got the chance to be the speaker at surgical grand rounds my senior year, right before graduation, from this woman that I'd sewn up for something like 16 hours that had been mutilated by her husband. And the thing that probably drove me into surgery were a couple of the people there that were on the faculty that I looked up to quite dramatically. And I got to work in Richard Lauer's lab a little bit during my last year in medical school there. Richard Lauer was the person that had the largest and longest string of heart transplants in dogs while he was at Stanford, and then came to MCV as the chair of cardiac surgery, and probably the most gifted surgeon I've ever seen. He made it, I got to first assist him, and he made it look so easy. I figured, well, anybody, I can do this. There's no big deal. So that's what led me into going into surgery, and was actually going into heart surgery when I left MCV. And had an interview at Vanderbilt and thought it was great. And drove all night that night down to the Medical University of South Carolina in Charleston, and they didn't impress me and I know I didn't impress them because I was falling asleep in every interview because I was so tired. And
from all the driving.
From all the driving, and it was supposed to come straight back up north to Richmond, and was going to stop at Duke and UNC for interviews on my way back. And I liked Vanderbilt so much and nobody ever told me that you had to apply to all these places. So I called from the interstate, I guess it wasn't interstate that time, at a gas station to Duke and UNC, and canceled my interviews and went on back home and applied to Vanderbilt, and I was lucky enough to get to go.
That's terrific. So you did your surgical residency at Vanderbilt University from 1968 to 1974. Surgical training has changed quite a bit over the last decade, several decades. And now we have a lot of the whole idea of 80-hour work weeks for training for residents.
Right.
And there's some talk that at some point it'll be a 50-hour work week.
Yeah.
What do you think about those changes in the work weeks for surgical training?
Well, I can understand the basis from which they are activated or pursued. I think they are a profoundly bad conclusion or management or solution to an issue of sleep deprivation or the like, because what they have done from my perspective is increase the risk of individuals going into types of medicine that require a complete commitment to have a full-time, part-time commitment, and that they've never been tested. And I guess in that context, I'm somewhat of the old school, because when I was a resident at Vanderbilt, we averaged as interns about 140-hour week. And you were up pretty much all night, every night you were on every other night, and you got home about 10 and you went in about 4.
Mm-hmm.
And that was an entirely different era where the definition of graduated responsibility was in fact a progressive graduated responsibility to an independent surgeon while you're a chief resident.
Mm-hmm.
So I think it's changed a lot. And I do understand the reasons for it, but unfortunately, I think lots of very important things are being lost in that translation.
Do you think that with the reduction in the work hours, so in your time doing 100, 140 hours a week to now 80 or potentially 50, do you think that that's going to require additional years of training, or do you think that changes in efficiency of training, so having mid-level providers do a lot of the things that were historically done by house staff?
Right.
What are your thoughts on that? Do you think the training will have to be extended?
Well, I think that the issue of work hours is, I guess, one generation away from the real issue. The issue is being certain that you, from my perspective, that the commitment to medicine
Mm-hmm.
is a complete commitment.
Right.
That it's not a job, a 9-to-5 job that you go to and then you have the rest of your life. You may be off call, but the commitment when you're caring for the life of another person ought not to be time defined.
Right.
And I think that's the worst side effect of the work hours, where if a resident were to stay a little longer and then have to, quote, lie about how long he was in the hospital because of his commitment to a patient that he was managing,
Mm-hmm.
is the most perverse outcome
Correct.
of a premise supposedly to make things better.
So, to change things a little bit, during the time that you were there during your residency, your original plan was heart surgery.
Mm-hmm.
What were the things that led you to pursue a career in vascular surgery?
I was actually going to be the last 1 year. When I went to Vanderbilt, you got opportunity to take boards in both general and thoracic surgery after an internship in 5 years. That everybody went through that program.
Okay.
And then while I was there, the Board of Thoracic Surgery required 1 dedicated year. And then the latter part of the time I was there, it required 2 dedicated years. And I was supposed to be the last 1 year guy. And in late September, I went in to talk to the head of cardiac surgery, and I don't know, when I walked out of the room, I thought maybe, without him ever saying that he was reconsidering anything, he made some offhand comment, and I stewed on it, and I started thinking. I'd written about 30 papers in vascular surgery about renovascular work and had done a bunch of stuff there. I actually had 1 year more, and then an appointment at the Heart Institute with Glenn Morrow to go as a senior associate there.
Mm-hmm.
So it was all planned out, and I started thinking, well, I'm going to have to sort of start all over again in working in heart, where I've done all these things in vascular, so they're about the same really anyway. And this is more diverse anyway.
Mm-hmm.
In many ways, it turns out more complicated. And so I went in to John Foster and asked him if I were to change, could I find a fellowship at that point, which was now in mid-October. And he called around and called Jack Wiley, who I'd gotten to know already and was a close friend of his, and they had just appointed their fellow for the next year.
Mm-hmm.
And there was this program in Chicago that had just gotten started, announced that it was going to start the next July. And so John Foster called up to Chicago, to Northwestern, and yeah, we haven't appointed anybody yet. And we would love to have Dick as our fellow. And
Mm-hmm.
so I came up here as a vascular surgery fellow and as a research instructor. I was on the faculty as a research instructor.
Mm-hmm.
For my fellowship year up here.
Who were the people that you would say had the most impact on your career plans and your experience during your residency, or the people that you would consider the heroes that you had interactions with during your time at Vanderbilt?
Well, I would have to go back to MCV, and I think Dick Lauer, the guy I spoke of earlier,
Mm-hmm.
Was the person that probably had the most impact on as seeing someone that was that level of a surgeon, that young in my professional lifespan, of how technical expertise should be done and its importance at the end of this game. That's what it's about in the operating room. But my residency at Vanderbilt, I would have to say that Bill Scott, Dr. William Scott, William Scott Jr., who was the chair of surgery there at that time, and John Foster, were the folks most impactful to me. And I think I got somewhat Dr. Scott served as my surrogate professional father. My father had died when I was 18, and he took me under his wing and throughout my residency, as far as I could tell. And I wrote a lot of papers with him on morbid obesity, and I think he had this unspoken wish that I would come back, and he spoke the wish when I came back on the faculty at Vanderbilt that I should start doing the operations for him. I'd been doing all the writing of all the papers and keeping all the data, but I told him, no, that's not what was in my lifespan. I hated surgery of fat people and had no intention at all in having that as part of my career. He got over that, but anyway.
So you pursued this vascular fellowship at Northwestern, and you were there from 1974 to 1975. And as you outlined, it was really a new fellowship. What were your expectations going in, and what did you get out of that time that you were there? Who were the people that you had a chance to work with while you were there at Northwestern?
Well, John Bergen and Jimmy Yao were the two faculty at that point. I worked very closely with Jimmy. He had helped participate with Giza Dutakas and Dr. Beal to find me a place to live with my family up here. I felt like I was going up to the wild Chicago, that I needed to take a machine gun with me, and they persuaded me that this was not necessary. So we rented a house in Wilmette, and I had the very, very fortunate event of every single day that I would drive over to Jimmy Al's house, and he and I would drive down from Wilmette to the hospital together. And as I've told people many times, and when Jimmy decided it was time for him to go home in the afternoon, my goodness, I had to leave too. So, but it was profoundly valuable to me because I had a tremendous amount of operative experience at Vanderbilt. I'd done like 30 renal artery bypasses as a chief resident, and none of those with Dr. Foster. He didn't operate. He would sit in the surgeon's lounge and check it out after you were ready to put the graft in, and then check it out after you put the graft in. And what I wanted was to I thought I knew as much as I needed to learn as a fellow or resident about that area of the body, but also wanted to learn about other areas. And Doppler ultrasound was just coming into its own, and to spend that time with Jimmy and working in the vascular lab with Doppler ultrasound. And we ended up writing one of the current problems in surgery on the use of ultrasound in vascular disease. And I worked as the teaching assistant with the chief resident, so I scrubbed on cases, but helped the chief resident, taught, I guess you would say, in many of the instances, the chief resident in the operating room that year. So it was a perfect experience for me. Most interesting thing was the other guy that was here, Paul Stanton. He spent his year at the Veterans Hospital, where he was able to get experience as being in charge, and I got to stay my year at Wesley. Had worked in the dog lab some on mesenteric portacable shunting, looking for changes for hyperlipidemia, and working with Jimmy and that arrangement at Wesley for the year. And I'll never forget that everybody, when I came up here, the plan that I'd never was for me to go back to Vanderbilt. And it had never been literally spoken that I was going to go back, but it was assumed by everybody. Spring comes along, and I hadn't gotten any invitations to go visit anywhere. And so one morning coming down to the hospital, told Jimmy that, I didn't know whether did I have a big problem or not, because Paul was getting invited to go to these places and getting wine and dined and put up in hotels and the like, and I hadn't gotten an invitation anywhere. And he said, "Well, Dick, you're going back to Vanderbilt, aren't you?" And I said, "Well, yes, but I mean, I'd still like to go be wine and dine somewhere and recruited." Because he said, "Well, everybody knows that's where you're going. That's why you haven't, but I'll take you out to dinner and ask you to stay here if you'd like." So we've had a good friendship for ever since that year.
So what was it like in the operating room with Dr. Yao and Dr. Bergen at that time as a trainee?
Well, we were, as I said, I functioned mostly as, I was the teaching assistant assisting the chief resident. So if I was scrubbed, relatively less frequently, or significantly less frequently, either one of them would be scrubbed. But I guess the best way to put it would be that I managed a lot more of Jimmy's patients than John's, in the context of working with Jimmy in the operating room than John.
As in your earlier years, where things were already mapped out for you about VMI and MCV, it sounds as if it was already mapped out that you were headed back to Vanderbilt.
Right.
So you went back to Vanderbilt and very quickly rose to the ranks there. And I noticed that you became the division chief within 3 years, a very rapid period of time. What led you back to Vanderbilt? And what are some of the things or thoughts that you had about how you wanted to structure that division of vascular surgery from the time that you were there as a resident and now coming back and taking the role as the chief?
As I said, I had never had ambition or looked at anything else or doing anything else. I'd been very involved with the vascular program at Vanderbilt and had lots of activities. I had always kept the data with myself for all of the renal artery data, and so there was never in question I was going to go back and continue to pursue the collection of the data and operating on patients and managing things. We had when I left, we had a SCORE in hypertension, a specialized center for research funded by the NIH in hypertension, and then when I came back, I was very involved in that. John Foster was at a point where he was nearing retirement, and after 3 years of my getting back, I think that without a discussion between myself and Dr. Scott, he was seeing that as a transformation. And so within 3 years, John Foster retired, and I was appointed to the head of vascular surgery, and there wasn't a division of vascular surgery at Vanderbilt until that time. He formed the structural appointment of a head of vascular surgery with my appointment, and it was interesting because the other places that the residents rotated were working with Andy Dale and Bill Edwards one at one hospital, one at the other, and myself at Vanderbilt. And so I was a fairly young person thrown into managing program for Vanderbilt that had Andy Dale as part of it and the like. But he was likewise very supportive of my career there and in that early phases of things while he was still working.
What were your primary objectives after you sort of got into that role? You had an understanding of what the overall framework was. What were your long-term objectives in building that division during your time there?
Well, I mean, we grew fairly promptly for the first 3 years I was there, because Dr. Foster really didn't take call or anything because he didn't operate. I was the downside of having a full-time vascular division was you had a full-time vascular division. So I was on call every night, 24/7.
So you were the division?
I was the division of vascular surgery at Vanderbilt. And so much so that I told folks that I did not carry a beeper because I was in the hospital about 18 to 20 hours a day, and if I ever got in my car to go home, at least I was going to say hello to my children and kiss them before turning around and come back to the hospital, and wasn't going to be interrupted going home. So, I mean, part of it was to grow the division. So we recruited in 2 folks in sequence to add to myself in the workforce, and my goals were to start a fellowship in vascular surgery at Vanderbilt. There had been one already active at St. Thomas with Bill Edwards and Andy Dale that was unrelated to Vanderbilt. And to continue my interest in renovascular hypertension and research in that. It got to where I was the associate director. After Dr. Foster retired, I was the associate director of the SCORE and the principal investigator of the randomized trial in medical versus surgical management of renovascular hypertension. We started a prospective randomized trial of asymptomatic carotid artery treatment, medical versus surgical, as a part of the SCORE as well, that we at that time had very much difficulty recruiting patients into the medical arm. Because they would refuse to run the risk of not getting fixed. But it was funded through the NIH for the NHLBI for my last 4 or 5 years there. I have some beautiful pictures of 95% stenoses of the carotid artery that remained 95% stenosed for 5 years in sequential angiograms. Probably the most fascinating was the ability to be funded from the NIH for the sequential study of people with a disease, untreated or treated. And we had a very large grant that paid for all of the hospitalizations of patients for evaluation of their high blood pressure, including angiography as the screening test.
As the screening test? As
the screening test. And a follow-up of patients who were found to be hypertensive with renal artery stenosis. They didn't even have to have renovascular hypertension. If they had a renal artery stenosis, they qualified for sequential follow-up.
Okay.
And they could get sequential angiograms. We had some patients in that era that probably had 10 or 12 sequential angiograms that they would come back on an annual basis for their angiogram. So it was a very rich data, and I think everybody that was involved in it. I was, at one point, was the only surgeon. They had a whole bunch of medical doctors that would rotate through the medical arm of the clinical trials, clinical arm of the hypertension center, but I was the only surgeon. And so I interacted more with medical physicians, clinical pharmacologists, and endocrinologists than I did with surgeons, but was exceedingly busy, in the operating room as I guess the busiest surgeon on the faculty as it relates to operative activities.
Mm-hmm.
One of the things that I have used in academic medicine as one of the principles, I think, of growing academic medicine or academic surgery has been that the difference between academic surgery and in practice is that you have the opportunity to create a niche. Hypertension was mine,
Mm-hmm.
and patients come referred to Vanderbilt for evaluation of their hypertension to identify if they had a renal artery cause. And at one point, we looked at our data about the cases for vascular surgery, and although 15% of the cases were renovascular surgery, 50% of the cases came from screening patients with high blood pressure and finding aneurysms, or
Wow.
just happened to also have claudication, or
Mm-hmm.
happened to have carotid disease that was found in this extensive evaluation of an atherosclerotic group of patients. So it was, from the very premise of vascular surgery, the entry funnel was a very broad-based entry funnel from which we got a tremendous amount of vascular surgery, totally unrelated to revascular work, but a lot of mesenteric disease and upper abdominal work.
It really is a great example of how this truly is a systemic problem.
It is.
And so you had, it sounds like, everything in place, things growing very well, very successful career there, but then you decided to move on and take a department chairman position.
I had looked at several different chair positions over the last 2 or 3 years that I was there.
Mm-hmm.
I had also been the chairman of the Vanderbilt Professional Practice Plan, of the group practice organization, my last 2 years there, and had interest in a broad range of things. And when I got the call to look at Bowman Gray, I really didn't know much about it at all.
Mm-hmm.
Everybody that I talked to said it was a very nice place, pleasant, good people. We had had surgical residents from Bowman Gray that were all very well trained as medical student graduates. And when I went there, it still is the single, to my knowledge, Department of Surgery, now Division of Surgical Sciences, that had every surgical discipline in it. And as a matter of fact, when I got there, ophthalmology had gone independent. And
Okay.
when I changed it from a Department of Surgery to a Division of Surgical Sciences, in which there were 8 departments, ophthalmology asked if they could come back into the umbrella because we had such a powerful institutional base for anything affecting the world of surgery, be it in the operating room or in the hospital or in the clinics or in the medical school. And everybody saw the value of being under one umbrella without the head of that umbrella being dictating how orthopedic surgery should be performed or neurosurgery should be performed. But as a collective under my umbrella, we had a very powerful, and still do, under the chair that's there, or the division director.
So you're slowly, at this point now, migrating more toward the administrative part of surgery.
Yes, but if you're familiar with the demographics of our country, North Carolina is in many ways ground zero for the stroke belt and many other factors. When I was still at Vanderbilt and I looked at all of that, it has one of the high, right around Winston-Salem, that region of North Carolina, a very high instance of end-stage renal disease,
Okay.
a very high instance of stroke, and a couple of other markers of atherosclerosis. And there was not anybody in that catchment area of patient population that was focused in any successful way on either renal vascular hypertension or complex vascular surgery. So when I came there, it was like a kid in a candy store. It was dripping with end-stage vascular disease and a lot of renal insufficiency caused by renal artery disease, much more so than what I had seen at Vanderbilt, though I had gotten patients referred from that region while I was at Vanderbilt. And so it was sort of a combination of factors. The Department of Surgery was very well off because it was a very, very active clinical department during the 10-year time frame that I was chair, or 10, we created 11 endowed chairs, at least one in each of the departments under the Division of Surgical Sciences, from excess clinical earnings and collections that came in.
That wouldn't happen today.
No, it sure wouldn't. So it was a very wealthy, we had something like a $25 million research and development fund. It was like 15 when I came. It was, and which I'll never forget John Sawyers, when I was telling him about what everything was there. He got a little bit jealous and said, "Well, Dick, I tell you, why don't you stay here and I'll go down." But it was very supportive of the things I wanted to do. It supported me to bring in a hypertension program from the Cleveland Clinic. I recruited down the entire research arm of the Cleveland Clinic's hypertension program under the umbrella of a fellow by the name of Carlos Feria, that had the longest standing program project grant in hypertension research. And so it was fun building things outside the realms of just hypertension, but building, we went from about 50th in the country in NIH funding as a Department of Surgery to our highest rank was 11th during that time frame in the country as far as NIH funding for research.
That's an amazing accomplishment.
So we really had it was fun getting to do things. Had a lot of opportunities to do things.
Great. I noticed that during the time that you were the chair there, you also served as the president for the Southern Association for Vascular Surgery. Tell me how that society impacted your career.
Well, you have to go back to the beginning of it because John Foster started it basically on an airplane trip between Nashville and I guess Roanoke, Virginia, because they were holding the Southern Surgical Association meeting in Homestead, and several guys on the plane were flying there as well, and that were leading vascular surgeons in the South. And John went up and down the airplane asking them if they'd have interest in forming a vascular surgery equivalent to the Southern Surgical Association. And then he called, of course, he had Andy Dale in Nashville already and Bill Edwards in Nashville, but called, I think John Oxner came up, Cal Ernst came down from Kentucky. I've forgotten all the others. There was about 7 or 8, and I was just back on the faculty at that point, or was the chief resident? No, I think I was just back on the faculty. And so I participated with them. They had a day's worth of work in outlining how it would be to use the bylaws of the Southern Surgical Association as the template to create the Southern Vascular Association, and work with them to exclude myself from membership, since you had to be out of your training for 3 years, and I'd just been out a year, so I worked with John to get it all created and work with him to get all the details worked out, and worked with the other guys as well in that context, and then was excluded.
So no special dispensation or anything?
No special dispensation. But I did get to meet and work with a lot of folks that were, I think I was blessed in my career in vascular surgery by having had the opportunity to be intimately interactive with a bunch of folks across the country that were pinnacles of their career at the time. And then when we did that, Jimmy and John, they were thinking about doing a Midwestern vascular Association, and so they called, and I came up, and I forgot which hotel it was, the Drake or where, but Emirates Shalagi and Jim Stanley, and obviously Jimmy and John Bergen and a couple of others, and myself. We spent a day working on the bylaws of Midwestern, which also, although I was said that I would be able to be a member, we progressively discussed everything, and likewise I was excluded from that one. So I went back to Nashville telling my wife at the time, saying, you know, I've been working on forming all these things, and I don't get to be a member of any of them. But anyway, in a very light-hearted way.
Mm-hmm.
But again, got to meet and work with folks that were at the pinnacle of their careers, and so it was just very fortunate.
Mm-hmm. Now, I also noticed that that wasn't enough for you. You decided that you wanted to do more and became the president and CEO at Wake Forest.
Health sciences. Well, this is also something that just sort of happened. It wasn't planned.
Mm-hmm.
Like none of this that I ever understood to have been planned was planned. But at Wake Forest, the North Carolina Baptist Hospital is structurally, governance-wise and administratively independent, had been independent of Wake Forest University and the School of Medicine, though you couldn't be you did not have admitting privileges to the North Carolina Baptist Hospital unless you had a full-time faculty appointment in the School of Medicine.
Okay.
So it was a absolutely closed shop, and all appointments were simultaneous. I was the chief of surgery in North Carolina Baptist Hospital as well as chair of surgery. But there were constant frictions at the edges of the relationship between the two organizations. And so about 1995, or 2 years before doing this, I came up with the idea of creating a group practice organization for the full-time faculty, which all of the faculty bought into very enthusiastically. We formed bylaws, and though it ultimately was under the umbrella of the senior executive vice president for health affairs,
Mm-hmm.
it was managed its own finances. Everything was placed under the umbrella that had to do with clinical medicine at Wake Forest. And then about a month or two after we'd gotten all this accomplished, the board of that group practice agreed with me, I was its first chair, to write a letter to the head of the hospital and of the medical school that the two should merge.
Mm-hmm.
And for the next 2 years, from 95 to 97, I was representing the faculty in merger talks between the hospital and the medical school.
Okay.
They came up with a bizarre, jury-rigged solution to irreconcilable differences, which was one job description for a leader of it, as the president of a combined medical center,
Mm-hmm.
occupied by co-presidents with one job description, and I, without having been asked, was to be one of those two people. And as it all got approved by the two governance boards of Wake Forest University, and it just kept going south from my perspective, and I thought it was a jury-rigged thing, so I went and told the university president that, you know, I was just a faculty member, so I had no authority over any of this, but I thought it was a terrible idea what had actually come up, and that I was not going to be serving in that role because I was going back to just stay the chair of surgery. I had a very happy life and wasn't going to sacrifice myself. And so then to come to find out, everybody thought that that's what I wanted to have done, and so it stopped. But my predecessor, Dick Janeway, was retired as a byproduct of all of this, and then they told me that I had gotten everybody hung out on this limb that I needed to take over because otherwise it wouldn't be right, so I did.
Mm-hmm.
And about a year and a half after that, the Wake Forest University board approved creating a separate corporate entity of the medical school.
Mm-hmm.
Wake Forest's medical school represents 65, 66% of the entire faculty of the university,
Okay.
60-some percent, or almost 70% of the revenues into the university, and half, at least half of the endowment and quasi-endowment of the entire university. And so we felt that it was being somewhat constrictive of what we could do when we had to play with the same rules as a very small, Wake Forest is quite small, undergraduate campus when all the other schools of the university. So the board approved us creating Wake Forest University Health Sciences, and I was the initial president of the new corporate entity. And also, since '97, served as the director of the medical center. Although we didn't merge, created a new affiliation agreement where there was a director of the medical center, an associate director of the medical center, and the hospital president was the associate director, and I was, as the senior vice president of health affairs, and then president of health sciences was the director of the medical center. So that's a lot more about it than anybody that didn't bleed through all of that would ever want to know.
That's pretty interesting.
But on my retirement, we were able to consummate the original plan, which was the president of the hospital was retired at the time of my retirement, and work through appointing a single leader for the entirety of the place. I had the title, but had no authority over the finances of the hospital.
Okay.
And this, John McCollum now has the position of both hospital and physicians and medical school all reporting to him, which was the way it needed to be done.
At what point did your clinical practice essentially disappear during these transition years?
I can almost tell you to the day, because after I took on the job in July, after about 3 months, it became clearly obvious to me that it was inappropriate to try to continue to do the type of surgery I was doing. And it was eating me up inside because I did not feel that I had the same level of oversight of the care of these elderly people spending days in the intensive care unit. And so I went to where I grew up in Radford. We have a cabin on a lake up there, and sat down with my older brother, and we talked about this whole thing, and I made the decision that I had to make a decision either to not continue in this job that I had just taken, or to stop surgery completely and put full time into this new job. And obviously, Kim Hansen I had recruited Kim in, and a superb technician, and had already been appointed. I had already appointed him before even become the head of the medical center as the head of vascular surgery, and he had a great program going and the like. And we had the Department of Surgery was taken care of, so I elected to just stop rather than do types of surgery that I wasn't interested in, because people wanted me to say, well, you can do carotid surgery and then you don't have to worry about it, then go home the same day. And I said, well, that's not what I enjoy doing. And, and I wasn't about to do a big aortic procedure, aortorenal procedures, and then have somebody else be responsible for caring for them. So it sort of stopped abruptly. But like most things that surgeons do, I have not regretted the decision. I mean, you don't ever want to find yourself regretting that you operated yesterday. So just not looked back about that. It was a phase in my life.
It seems to me that that position is really a full-time position, and that many times as practicing physicians, particularly the younger generation of physicians, don't understand the implications and all the nuances of what goes on at the administrative level. Oh, what are the key things that you learned when you took that position on that you hadn't really appreciated when you were clinically busy?
That's an interesting question, because I knew pretty much all of the financial pieces of the medical center while I was still the head of surgery, because we were responsible for 40% of the admissions. We were responsible for 40% of the of the entire revenues coming into the medical school, into the hospital, and so I had personally a fairly acute knowledge of the interactions between all of that before I took the job and understood the shell games or whatever were going on. The things that I had no experience in nor engagement in. I went to the hospital at 5 in the morning. I came home after dark at night, and never went anywhere else in Winston-Salem. When I started taking my youngest son to school, as an example of that, when I was single with him, and he finally got to where he was just going to see how far towards the hospital I would get before I realized that I was driving him to school. Because that was, you get in the car, you go to the hospital.
Yep.
So I had no experience with dealing with boards.
Okay.
I didn't know how you were supposed to deal with them or how you were not supposed to deal with them. I've never interacted in the public in Winston-Salem until that point, but not because I certainly did not read a book on how you do it, and I probably made hundreds of mistakes in doing it, but I had a very close relationship with the board. I just assumed that they were interested in what we were doing and that they would want to know what we were doing. I didn't play the games with them about holding information back or sugarcoating anything, because I had gone through this 2 years of negotiations with the hospital with my board, and lots of things came up about how management of the medical school and of the hospital were that I did not want to replicate. So I sort of learned on the job about interacting with the public, with the community leaders. And the first thing I did was go talk to the community business leaders, which included the head of R.J. Reynolds Tobacco, when that was the site of RJR, Wachovia, when Wachovia was Wachovia, that's its home, Piedmont Airlines, and a few others like that in Winston-Salem. And one of them said, well, Dick, you know, let me just tell you how we see the medical center, and there is that if you all had a dry cleaners and a movie theater, you wouldn't need Winston-Salem. Now, we're the biggest employer at this point by far in the community. And right as I took over the job, that was such a profound statement of our relationship with our community when we had, because of them downsizing of rentals and the like. So I basically felt a very deep commitment to the community as controlling the largest employment base of the community. And so that led to getting out involved. We started a 200-acre urban-based, could be the largest when it's finished, urban research park out of space right downtown Winston-Salem. And because of that, got very involved with the state legislature and the state leadership and federal government as well relative to economic development. And it's just one thing begetting another and begetting another, without there being a master plan for any of it, just moving with what happened.
And it seems like each step of the way, you really adapted to each one of those challenges as they came along.
Well, I guess things that I have taken on, and I guess it's treated from the very young age with my father, is that if you commit to something, you're committed to it. And right. You don't take on things unless you intend to be committed to them. And once committed, and if you have a competitive personality, you don't want to lose, I guess. But it has been at each phase of my professional life a very rewarding. As I've looked back on it, it's really been based more on interest on what's just on the other side of the potential fence line. And if there was no fence there, couldn't we have a better, what we're doing, whatever that is, be it vascular surgery or the medical center, could get more accomplished if there were no fences around us.
Well, you've obviously had a spectacular career, and you've had innumerable contributions to surgery and vascular surgery in particular. But I'd like to take the next few minutes to focus on some of the key areas in vascular surgery. And you touched upon this earlier when you were speaking about your experience during the time at Vanderbilt and your interest in renovascular hypertension and such. What are your thoughts now with the development of endovascular therapies? Do you feel that it's a reasonable alternative? Do you think that we're being too aggressive in our treatment? What are your general thoughts, especially with your background?
Well, I guess I'd have to give the first prefaces that I have not stayed as intimately to date on the last paper that was written about the different methods of managing it. But having said that, I think the trends that I have seen throughout the time have been that the easier it has gotten to treat by some less invasive methodology, the less interest there is in proving that you needed to do it in the first place.
Okay.
And thereby, many more people are being treated, even if it was going to work forever, than need to be treated. And at least at one point when we were putting people through an immense evaluation to prove that it was needed at that time, less than 50% of people with a hemodynamically significantly appearing renal artery stenosis had renovascular hypertension. And although all vascular disease progresses, it doesn't progress in a linear way, and it can stay the same for many, many years. And I have not been as impressed with the renal function retrieval, magnitude of retrieval of renal function from the intraluminal device-treated renal artery lesions, as at least the experience we had with open procedures. So I recognize I never did it any other way, but I think the biggest concern from my perspective is just that the science and the intellect have a much more difficult time wedging itself into the brains of the majority of people who are using these easy modalities.
Mm-hmm.
Because since it's so easy and you can do it so quickly, why not do it to everybody?
Right.
And the attendant cost and et cetera, et cetera.
Now, the other thing that was a real highlight, in my opinion, and I think is many people recognize this, is your role on the American Board of Surgery. So you served as the director from 1993 to 1999, and during that time there was lots of discussions about the creation of a sub-board focused on vascular surgery, and I know that you were very much involved in that. Can you give us a little bit of insight on how that got started?
Well, yes, there was about the time that I went on the board, I mean, almost simultaneously, there was this growing sense of alienation on some parties' minds regarding the stature of vascular surgery in the minds of the world of surgery, the degree to which uninformed people were supposedly at least constraining vascular surgery in its directions and dictating to vascular surgery what it could and could not do. There was complaints that the American Board of Surgery and the RRC were being inappropriate in some of their complaints about some of the vascular programs. I did not share that view. I thought that everybody was trying to do what they thought was right at the time. Mm-hmm. But with that sort of separatist, secession emotion growing in some sectors of our field of vascular surgery, it was about when I went on the board. And I think my first or second year or third year on the board was when the issue was coming to a much greater point of political and hostile interactions. and we decided to hold, the American Board of Surgery has a winter meeting every year where it's a 3 or 4 day, I forgot, 3 days worth of meeting at somewhere in a retreat format.
Mm-hmm.
We decided to devote the retreat to a discussion of the issues surrounding vascular surgery and their interest in being independent of the American Board of Surgery. Being the only vascular surgeon on the board, I was asked to give the views of what I saw was needed to be done.
Mm-hmm.
And I think I still have somewhere in the bowels of my boxes at home the speech, but it was basically a discussion of parenthood and of maturation of children.
Mm-hmm.
And its transference into organizational structures. And I started by making the point that the reason that there are so many, told them my pedigree, that I had a deep commitment to maintaining the unity of surgery at Wake Forest with every discipline under one umbrella. And the way that, what has happened at most places is that the chair, or the chief, wants to have that position of power and the entire environment be dictated by his vision of how the structure should be coming to him, instead of understanding that each of those disciplines, that he doesn't know jack about them,
Mm-hmm.
and that there needs to be a separation between strategic oversight and tactical management of things. And then I translated that over into the boards of medicine. If you look at the American Board of Medicine, it has all of these under it, cardiology and blah, 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 all of them are under the one. And I said, you know, we have the opportunity at this point, at each point in American Board of Surgery's past, the entity wanting to have its own, define its own destiny, has been constrained to the point that they bolted. And the American Board of Surgery insisted on maintaining it as a child long beyond adolescence, and to the point that they would then become divorced from their parenthood.
Mm-hmm.
And that's what's happened with, and I went down each of the respective boards, orthopedic surgery, of urology, of neurosurgery, all of these different specialties,
right,
finally said, you know, Jack, I'm out of here.
Mm-hmm.
And it was not because they weren't a mature specialty, it was because the American Board of Surgery did not broaden its umbrella,
mm-hmm,
and take a step up in the stature of what it's supposed to represent to an overarching board in which all of the intramural management of that discipline were delegated to the sub-board. And believe me, vascular surgery is not going to be the last one. That was my point at the end. I listed off the others. The oncology surgeons are going to want that. The pediatric surgeons basically already have that because
right,
they're under the umbrella. But oncology was, trauma would, the GI, I mean, all of these have the opportunities at points to be maturing, and we have this one last opportunity to come up with a structure that will assimilate the opportunities for all of these respective disciplines to mature and become adults while still having a family
mm-hmm,
under one umbrella when it comes to strategic issues relating to the discipline of surgery. Bill Baker was there. I think he was either the president or one of the officers at that time of the societies. He, and I've forgotten who else was there from the vascular societies at the time. And by the time the retreat was over, I think it was a pretty well, I don't know whether it was unanimous or not, but the vast majority of people there did have an appreciation that if we wanted to, you couldn't stop people from growing up.
right,
The issue is what's going to be the relationship of your children when they're adults.
mm-hmm,
And they all sort of, I think, bought into the idea of having the structure that we now have. That's continued as well to be refined somewhat over the years since then. But that first step of recognizing that you can be big enough, and I think the leadership of the American Board of Surgery saw that their role really should be elevated beyond details of daily life in any of the disciplines that it oversees.
I think that's a great analogy. The parent-child-adolescent analogy is a really good one.
Well, that's true about everything in business or professions at any level. And because humans are humans, you continue to have the issue of how do you transition that phase of the life of the parent to the child that is going to go to become a parent, and how much trauma occurs before the finality of adulthood and its interactions between generations occurs.
So what we were talking about was that one of the other unique things is that you and Jim O'Neill wrote a textbook focused on vascular disorders of childhood. And as far as I know, that is the only textbook that looked at vascular disorders for children.
Yeah.
What led you to put that together? And what are your thoughts about vascular disease in the young patient population?
Well, I had been working on doing that book for about a year or a little longer, and it was clear that the rate with which I was able to write chapters myself was going to be so slow that no chapter would be relevant by the time I went to the next one. I think I did about a little over half of the chapters. I asked Jim if he would join me, and then Jim had to write a few chapters, and so he and I put it together with other faculty members at Vanderbilt. I was interested in it because of the renovascular hypertension interest. One of the areas of unique referrals that I had was a very interesting referrals of children, even babies with hypertension up through adolescence that had at different stages of life manifestations from different causes of renovascular disease, and because of that saw in the penumbra of that focus lots of other semi-related or unrelated, because you know this, you obviously must know that, which you subsequently learn. A lot of referrals of children with AV malformations and the like, and I recognized at the time that there was no book on vascular surgery in childhood, and so it was a niche that I thought would be fun to fill. It was done the last year or a year and a half before I left to go to Wake Forest. It was to start a whole process of books on vascular diseases, peripheral vascular diseases, that Saunders was going to do with me, looking at the disease rather than the surgical management of the disease. It seemed to me that we call ourselves now vascular surgery and medicine, that our default interest is in the intervention rather than the understanding of the disease itself and its natural history. So I thought it would be a great value to have a set of books focusing on the disease, not its treatment. And at the end of it, figuratively speaking, saying refer to so-and-so for treatment or whatever. But having left right as when I got the call in Wake Forest, that whole thing fell through the wastebasket, and the book on vascular disease in childhood was the only one. The scary, in some ways, piece of that book was I was literally at my desk at my home writing the chapter on arteriovenous malformations when my, at the time, 6-year-old son came to my desk and showed me his arm, which it took me 2 examinations. The first one I told him it looked like a bite, go away, and he came back a couple of days later and when we discovered and diagnosed his arteriovenous malformation in his arm.
Wow.
It made me focus very astutely on what I was going to be writing about from that point in my life forward, because I was afraid somebody else might come in with whatever the disease was that I was writing about. But
So it really hit home.
well, it did. I mean, it was weird.
Mhm.
I mean, the combination of those two, and unsolicited, him walking up as I'm sitting there out of how many nights did I work on anything at home in my
Mhm.
lifetime?
Now, you're a recipient of several distinguished awards throughout your professional career. Which are the ones that do you treasure the most, or the most meaningful ones? And I know that all of them are important,
Yeah.
but there must be a few that you really are they're special to you.
Well, I have had a life, my professional life, I've had a relationship with the University of Vienna. So receiving their honorary doctorate degree from Medical University of Vienna is right there at the top of everything. My Medallion of Merit from Wake Forest, which is given as Distinguished Service Medallion of Merit, that they give to someone on a repetitive basis, but receiving that meant a lot. And I guess the third being my receiving the award as the Distinguished Alumnus from MCV, is likewise made me feel full circle that back where I started.
Mm-hmm. What's your favorite operation? If you had to choose one operation that you could do, what would be your favorite one?
It would be on a child. I would like to have that child be about 7 or 8.
Mm-hmm.
And it would be a subisthmic coarctation of their abdominal aorta involving their visceral and renal vessels. And because it is such a, one of my teachers at MCV, when I was doing the sexternship we spoke of earlier, looked at me one day and says, "Dick, it's almost sinful that we charge people for having so much fun." And ever since then, when doing those operations where you can do such a profound amount of display of dissection and exposure, and can do just about anything that you need to do to a kid, and they'll, yawn and get up and go out and play ball the next day, so to speak. And that procedure that we did on a few kids is an anatomic repair. As I used to say, that this is the way the Lord made them, and this way we'll have them grow up as well, with an anatomic repair rather than multiple grafts everywhere.
Right.
It requires an extreme amount of exposure, but at the conclusion of it, you've sort of fixed them the way they're supposed to be.
Oh, that's pretty neat.
Yeah.
Outside of work, you must have some creative outlets, something that provides some balance or enjoyment. What are the hobbies that you've had throughout the years?
Well, I sort of laugh about the word balance. That seems to be a lexicon in the current era of medicine, that you have to be balanced. I've had faculty at times comment that it must be weird because I don't have balance. I grew up in a family where medicine was, and the family understood that and interacted, and if you're leading a life that you should be for your children, of demonstrating commitment and accountability and responsibility, and preaching those into them by both preaching and behavior, there's less time for balance or hobbies. I love to play golf. I play it about 3 or 4 or 5 times a year. I love to go fishing at our lake house. I do that about 3 or 4 times a year. Well, until now. I caught my biggest fish up there. But
How big was that?
it's about 10-pound catfish, 15-pound catfish, and about 30 inches long. But I love woodworking, as I think probably a disproportion of retired surgeons do, building things. And I'm enjoying just being involved in a lot of other worthwhile things like Boy Scouts and work with the state on committees and boards with the state.
Before we finish, I'd like to close with a few of your thoughts on the future of vascular surgery and words of wisdom for the next generation. I know since 2008 you've been involved in your consulting firm, SV21C. What are some of the key trends in healthcare that you've witnessed, and what are the things that vascular surgeons need to prepare for in the future, in your opinion?
Well, I think that if I observe what is happening in a positive way and the directions that healthcare delivery needs to go, from my perspective, it is going back to this whole premise of disjointed parties, where the discipline of nursing, the discipline of physicians, of family practitioners, of physician assistants, of pharmacy, of blah, 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 are all managed, licensed, and governed as absolutely, totally independent entities.
Mm-hmm.
And then you go into this other room, and everybody is asking, I would say demanding, that there is a cohesive, coordinated approach to the caring of a person. And that there are no, quote, dictators that own the ship. There are people that all work in a very cohesive, interactive way. And I guess I would argue that this applies to the specifics of a discipline like vascular surgery, as well as the professions of healthcare delivery. That what we have been living in historically is a pyramid that's upside down, where all of the power has originated at the top, and whatever the top, the physician, did not want to keep, he delegated down to the next level and agreed to let them do that.
Mm-hmm.
So, and the next level kept everything they wanted to keep and delegated down to the next level.
Mm-hmm.
And effectively what we need to do is to start from the new up and flip the pyramid up the way it's supposed to be and say what can be done, be it in other disciplines or in the world of vascular disease, what can be performed appropriately and with value by the lowest level in the healthcare team, and therefore what's next for the next layer, and what all they can do, and then what's left over for this. And so the role of the physician, the role of the vascular surgeon, or the vascular specialist, will become, if they are interested in being something other than a technician, will become much more of an integrator and overseer, if you will, of being certain that these pieces are being done by the components that need to be doing, rather than spending a ridiculous percentage of time doing things that someone with 10 years of postgraduate education and training, 4 years of medical school, and 6, 7 years of residencies or whatever after that. So I think the biggest issue is how to approach a new paradigm of healthcare delivery in a way that minimizes the misuse of the intellectual properties of all of the interested parties, from the nurse's aide or social worker all the way up to the vascular surgeon, be it if it's vascular surgery. I think the biggest risk that has to be managed, from my perspective, in any of the disciplines, but especially in physicians, and especially in those disciplines of the profession of medicine that have historically had the greatest required commitment, that as we put in all of these walls or hurdles or thou shalt nots, you can't work harder than this, you can't do that, is that there are some principles that are having profound negative impacts on the purity of the calling of medicine. And it is becoming this quote balance is between part of my life and my commitment is here, and then I have this part over here that I'm a physician.
Mm-hmm.
And so I'm a full-time part-timer.
Right.
And that's philosophically I'm very opposed to, because you need to figure out a way to have that commitment dilute itself over into your family to where you are someone that your children can emulate wherever they go. And I have 4 sons, maybe one of them, the youngest, might go into some field of medicine. The others saw me working all the time and then, no, I don't want to do that. But they learn the basic core principles of commitment, responsibility, and accountability. And so I fear that in the process of us doing all of this and restructuring, if you will, that and the confinements that all the rules and regulations are being placed on us, that we will lose the values related to having the profession, and then on top of that have this altered role over here that we could end up becoming more clerk than business owners, if you
Right.
will, or being committed to it as the ministry is.
Over the years, what have you found to be the most valuable learning experiences?
Well, I guess my answer to that would be that what I have found to be the consequences of my experiences that's been of most value is every time I have looked to the periphery of whatever my responsibility is and seen how that could be, learning about that could improve what I am doing in my area of responsibility. And I've learned as a byproduct of that a bunch of things that I never went to school for.
Mm-hmm.
My English teacher would drop dead if she thought that I ever wrote a paper. I mean, my life has been an evolution, but it's been because one is always looking at the edges of what their comfort.
Right.
And I think all of us become progressively more comfortable with where we are because it's comfortable. And the older we get, the less likely we are to make ourselves uncomfortable by getting into territories that are not ours, that we control. But I would think that's what life is supposed to be about, is moving the fence line, so to speak, or removing the fence line and getting out into other areas of discomfort that you can then bring whatever knowledge or talent you have to a larger engagement. And that approach, I think, is what I have looked back at my experiences and saying it's sort of that strategy or philosophy, and it's all been about having, in many ways, a very serious definition of fun. Of the unknown, if you will.
Well, thank you very much.
Thank you.
In the summer of 2018, Dr. Dean's book, Strong Medicine for Winston-Salem, was published, chronicling the 10-year effort behind the development of the Piedmont Triangle Research Park.